inability to bear weight, reduced range of motion, fever, chills, nausea and myalgia, arthalgia, and fatigue. Vital signs may show fever, tachycardia, or hypotension in case of septic shock. Mm, Physical examination typically discloses tenderness to palpation of the affected joint, a limited range of motion, pain with range of motion, joint effusion, and overlying cutaneous erythema. Potential routes of infection include direct inoculation, spread from and adjacent infections such as osteomyelitis or hematogenicity, a structurally compromised joint such as prosthetic joint, or a joint affected by years. Inflammatory arthropathy may be more susceptible to infection, especially mm, if the patient is also systematically immunocompromised. Diagnosis is through clinical examination plus arthrocentesis, which classically disclose neutrophilic predominant exudate with a white blood cell count greater than 50,000. Organisms are often seen on gram stain and are detected by culture. Treatment include IV antibiotic plus emergent operative debridement to prevent complications such as articular erosion, fibrous ankylosis, loss of ability to ambulate, and the potential sepsis and death if severe. Okay.
Can you
Oh,
raise
yes.
D? Oh,
The
that's Agalaki. Never mind. That's Agalaki. I thought it was Biogenes. Never mind. Never mind.
why not Pseudomonas?
Oh, okay.
Oh, yeah, Pseudomonas including UTI, osteomyelitis, otitis externa, folliculitis, hospital or ventilator assisted pneumonia, and bacteremia.
Yeah, it doesn't cause septic.
Normal like septic arthritis, the most common organism is staph.
Mm-hmm.
Okay.
Mm-hmm. 42 men, physician, because right shoulder pain for 24 hours. The pain began 8 hours ago after he spent the day painting his house. The pain increases when he raises his arm, and he's unable to actively abduct the shoulder beyond 90 degrees. Passive range of motion of the shoulder is full and causes only mild discomfort. X-ray of the shoulder is here. What is the diagnosis? I did not see anything on the X-ray. I
X-ray
mean,
is normal. Inability to abduct the shoulder beyond 60 degrees. So that is the clue.
I don't know if that's a clue, but okay. Um, mm, 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 mm. Ready?
Okay. The supraspinatus tendon is the most common location of the rotator cuff injury. The supraspinatus tendon is the most common location of the rotator cuff injury. Supraspinatus muscle line the supraspinatus muscle line the supraspinatus fossa along the superior portion of the scapula, and its tendon inserts on the greater tuberosity of the humerus. The supraspinatus muscle contributes to the initiation of the arm abduction prior to the action of the deltoid muscle. Injury to the supraspinatus tendon may occur from degeneration, impingement, overuse or trauma, and can be evaluated through abduction of the shoulder against resistance. Classic symptoms include pain with active shoulder abduction, active shoulder abduction during which the tendon is placed under tension by the muscle, which is relieved with passive abduction as no tension is generated on the part of the patient. Treatment includes rest, ice, anti-inflammatory medication, and physical therapy.
You read A, C, and E.
Yes, biceps tendon rupture results in weakness of the elbow flexion. Biceps tendon rupture results in weakness of the elbow flexion and forearm supination along with retracted prominent deformity, the retracted and contracted muscle in the anterior aspect of the proximal arm. On physical examination, the biceps muscle consists of a short head originating from the coracoid process and the long head originating from the intra-articular supraglenoid tubercle. The biceps brachii inserts at the radial tuberosity. Mm, glenohumeral subluxation. Glenohumeral subluxation, a partial dislocation of the shoulder joint, often arises from acute or chronic disruption of the muscle, ligaments, or soft tissue bones that comprises the joint. It presents with shoulder pain, deformity, limited mm, passive and active range of motion, generally following traumatic injury sustained by the shoulder when weightlifting or playing sports. It is generally diagnosable on X-ray. Torn glenoid labrum presents with shoulder pain with range of motion, limited range of motion, catching or locking sensation with motion, and occasional instability of the shoulders. It generally results from acute trauma and is diagnosed by physical examination and MRI. Okay.
Six, 68 women evaluated in Africa because right foot pain one day after cholecystectomy. She says the pain is sharp and intense, and she has never felt anything like this before. No history of trauma to the area, temperature fine, pulse is fine, it's a bit high, respiration fine, BP, it's fine. A pulse oximetry 96, physical exam shows hairpin nodes on the fingers and crepitus of the knees. The right foot is red, extremely tender to palpation and warm touch. Joint aspiration is done. Photograph of the feet and synovial fluid is shown. Administration of which of the following is the most appropriate next step?
It is a negative bifringent crystal, isn't it? It is gout.
Uh-huh.
So I think that colchicine, it is acute.
Okay. Ready.
Colchicine is a microtubule inhibitor. Colchicine is a microtubule inhibitor. Colchicine is a microtubule inhibitor. Is commonly used in the treatment of inflammatory arthropathies such as gout. It acts by preventing and migration of the neutrophil to a site of inflammation through several mechanisms. Beyond these are proposed. Gout is an acute monoarticular arthropathy resulting from an intra-articular inflammatory reaction to the precipitation of monosodium urate crystal within the joint space. Precipitation can result from overproduction of the uric acid, but more frequently occurs following underexpression of uric acid. Gout typically presents with acute traumatic single joint pain, erythema swelling, which can recur in patients who are under or untreated. The most common joint involved in the first metatarsophalangeal as shown in the photograph, but the other common joints include knees and elbows. Diagnosis occurs through arthrocentesis, which will disclose needle shape birefringent crystal. Certain medication loop diuretics, malignancy, and existing joint disease are predisposing condition. Treatment consists of non-steroidal anti-inflammatory drugs, colchicine, a corticosteroid exhaustion. Okay.
Asymptomatic 47 woman comes to physician for routine. She has hypertension, hypothyroidism. During childhood, she was told she had a heart murmur. Um, Current medication is sinopril, thiazide, levothyroxine. She does not smoke. She BMI is fine, pulse is fine, blood pressure fine. Oral exam shows dark, cracked right lower molar with swelling, erythema, and tenderness of the gum. Lungs are clear, cardiac exam is fine with variation on the S2 on respiration. Patient is scheduled to undergo root canal at the dentist next week. Which of the following is the most appropriate recommendation for antibiotic prophylaxis prior to the scheduled dental procedure?
Okay.
Okay, you can read.
Yes, no prophylaxis or no prophylaxis is indicated prior to dental procedure in a case of no longer apparent childhood, no longer in case of no longer apparent childhood murmur. Guideline exists the prevention of bacterial endocarditis related to dental procedure. Bacterial endocarditis related to dental procedure manipulation of oral mucosa. Manipulation of oral mucosa can result in hematogenous spread of oral flora, which in the setting of compromised heart may promote infection and colonization of abnormal dysfunctional endocardium. Qualifying dental procedure for which qualifying dental procedure for which prophylaxis is recommended include any procedure in which manipulation of the gingival tissue or periapical teeth occurs in any patient of the perforation of the oral mucosa. Guidelines of American Heart Association recommended antibiotic prophylaxis in the setting of prosthetic cardiac valves, prosthetic implanted materials such as angioplasty rings, cords, previous infective endocarditis, unrepaired cyanotic congenital heart defects, repaired congenital heart defect with residual shunt or regurgitation adjacent to the site of the patch or prosthetic device, or in transplanted hearts with structural abnormal valves. Non-cyanotic congenital heart defects such as ventricular septal defects, especially if resolved, do not require antibiotic prophylaxis unless another indication is present. When indicated, antibiotics that cover the oral flora should be administered 30 to 60 minutes before the time of the procedure uh, as a single dose. Okay, oral amoxicillin. We have found a question where there is oral amoxicillin before dental procedure would be correct in case where prophylaxis is indicated before, provided there are no contraindication of the antibiotic allergy. Second line antibiotic, clindamycin macular. So previously we have done a question where the oral amoxicillin 1 hour before the procedure, isn't it? Where is
Um,
that?
I I don't know. I don't think it was in this CMS.
No, no, in it is not in the same. So I think that somewhere. Okay, this is a bit confusing.
Why?
Like this type of question, I get confused. Like, do you have a clear concept like in this concept, like in infective endocarditis, like where to give prophylaxis and where to not?
I think it's. I mean, what they say here, like if it's usually it will be pretty clear. Like they will tell you the person has prosthetic, some kind of prosthetic thing
Valve.
in the heart.
Okay.
Yeah, I don't have to be even if some kind of
So
prosthetic thing in the.
childhood murmur is not an
It has to be cyanotic. The key with the congenital heart defect, it has to be cyanotic. If it's not, the only question that I remember finding, they would specifically tell you it was is cyanotic. And then if it's cyanotic and it has been repaired, but then it has been repaired and there is still some like a murmur, then you still have to give it. But usually it will be like it's cyanotic, so you will know, yeah, you have to give it. And then I think just remember if there is some kind of prosthetic and if it's cyanotic congenital. I think that will be
then
those are,
then
then you
we
give,
need the
yeah.
okay.
Because here it's congenital, but it's not cyanotic. That's why you're not giving it. 48 men, 6 month history of pain in both buttocks when he walks and erectile dysfunction. Has been a heavy smoker for 20 years. BP in the lower extremity is less than half of that in his arms. So I guess like low BP in the lower extremities. Serum cholesterol, I guess, is high. What's the diagnosis?
No, rectum, 6 months of pain, both buttock on the
Ready?
okay. Is it Lee Rich syndrome?
Probably not. It's not. But it's a similar. I mean, not really.
Okay. Atherosclerotic narrowing of the distal aorta. Aortic atherosclerosis commonly occurs at the aortic arch where it serves as a major risk factor of where it serves as a major risk factor for cerebral embolism, and in the abdominal aorta distal to the renal arteries. Aortic atherosclerosis may lead to ischemia. Aortic atherosclerosis may lead to ischemia of the lower extremity and presenting with the buttocks and the legs, lower extremity pain, paresthesia, paralysia, shiny, hairless skin, and erectile dysfunction. A careful examination with attention to the lower extremity pulses is crucial to distinguish an acute or chronic ischemic cause from potential neurologic causes. The diagnosis of the aortic atherosclerosis is supported by CT or MR angiography, along with assessment of the ankle brachial blood pressure indices. Prompt perfusion is essential to prevent further loss of function caused by hypoperfusion and can be accompanied with balloon or stent angioplasty, aortic endarterectomy, vascular bypass surgery, aortofemoral vascular bypass surgery, a- aortobi- uh, by vascular bypass surgery, aortofemoral bypass grafting, or thrombolysis or thrombectomy in case of acute plaque rupture or embolic occlusion. Modifiable risk factor for aortic atherosclerosis include hypertension, hyperlipidemia, diabetes, and cocaine.
62 men comes to the ED because 3-day history of progressive shortness of breath. He has not had chest pain, autopnea, paroxysmal nocturnal dyspnea, completed chemo for small cell lung cancer 10 months ago. He has long-term history of nocturia twice nightly that resolved over the past 3 days. Hmm. He smoked a pack of cigarettes for 30 years but quit a year ago. Pulse is high, BP low. There is jugular venous distension to the angle of the jaw. Lungs are clear, heart sounds distant, liver is tender and big, no pedal, no pedal edema. Hemoglobin, I guess that's low. Sodium, I guess that's normal, a bit low, normal. Chloride is normal. Wait, no, chloride is high. Potassium is, let me remove this one. Potassium is normal. Bicarb is high. No, 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 no. It's normal. Urea is high and creatinine is high. ECG shows decreased QRS voltage. X-ray of the chest shows an enlarged cardiac silhouette. The cause of these findings is an abnormality of which of the following? Hemoglobin, I believe, is low. Chemo.
Please give me
No.
activity distance, hypertension, hypertension, distance, distance versus cardiac. Is it cardiac tamponade?
Mm, probably. Mm,
Okay.
okay, ready?
Yes.
Yep.
Okay. Fluid that accumulates within the pericardial space. Fluid that accumulates in the pericardial space is rapid onset or a large volume fashion that can result in pericardial tamponade, compression of the cardiac chambers, especially the right ventricle, impairs cardiac filling with resultant decreased cardiac output caused by low stroke volume. Severe cases result in obstructive shock, manifest by tachycardia and hypotension. Physical examination include dextro and hypertension distant the neck and distant person. ECG may disclose low voltage. ECG may disclose low voltage electrical alternance and there may be pulses paradoxes on evolution of blood pressure. Treatment requires emergent pericardiocentesis to restore the diastolic filling and cardiac output. Predisposing conditions include but are not limited to the malignancy. Okay.
52 woman comes to the ED because of 1-day history of progressive shortness of breath and right upper abdominal pain. Right. She has been unable to sleep while supine because difficulty breathing. She underwent chemo 1 year ago for breast cancer. She has COPD. She has smoked 2 packs for 30 years. Temperature is high, pulse is high, respiration, I guess, high. BP, cannot even see. Low. Exam shows jugular venous pulsations at the angle of the jaw, so high. With the patient in the upright position, lungs are clear, heart sounds are distant, Grade 2 out of 6 systolic normal. Heard abdominal exam shows diffuse hepatomegaly, 2 plus speeding edema, 2 plus pedal edema. Urea is high, creatinine is high, ECG is shown. Most likely explanation for these findings. Wait, was lungs are clear.
What is your diagnosis?
I don't know yet. Let me
Distant
see.
heart sound, hypotension,
Oh, so same
distended
thing.
neck vein. And in the ECG, there is electrical alterness, like low voltage ECG with electrical alterness. Like this is one. Okay, you were right. I think so.
Uh-huh.
Okay, it's pericardial effusion. This patient's presentation pericardial effusion may include a range of asymptomatic to severe symptomatic cardiac tamponade, severe symptomatic cardiac tamponade, large volume or rapidly accumulating cases, compression of the cardiac chambers, especially the right ventricle impairs cardiac filling and decrease the cardiac output, low stroke volume. Presenting features include but are not limited to a history of chest discomfort, shortness of breath, decreased exercise tolerance, fluid retention, lightheadedness, along with any historical feature that may explain the cause of effusion, weight loss, or history of malignancy in case of malignant effusion. Vital signs may be normal in case of small effusion or may include tachycardia and hypotension in cases of temperate. Physical examination findings includes vague shred, hypotension, distant neck vein, distant heart sound. In case of temperate, these findings occur because the presence of the fluid in the pericardial space, muffling heart sound, and increasing collapsing pressure on the right ventricle, which is transmitted to the vena cava and their tributaries. In such in such a manner, increased right heart pressure is reflected and increasing collapsing pressure on the right ventricle, which is transmitted to the vena cava and their tributaries. In such a manner, increased right heart pressure is reflected as the jugular venous distension. ECG may disclose low voltage or electrical alterness. There may be pulsus paradoxes or eventual blood pressure. Confirmatory diagnosis requires visualization of the effusion, often on echocardiogram. Okay,
Can you repeat the?
yes, cor pulmonary refers right heart failure secondary to chronic pulmonary pathology with increased pulmonary vascular resistance and right-sided heart pressure. It can result from many conditions such as chronic obstructive pulmonary disease, interstitial lung disease, thromboembolic disease, systemic scleroderma, primary pulmonary hypertension. It may present with JVD and edema but not generally present with electrical alternance and low voltage ECG. ECG findings may include signs of RVH, right ventricular hypertrophy. Pulmonary emboli classically present acute chest pain and shortness of breath. Predisposing features include hypercoagulability and embolization. The physician, the physical examination is often normal, though occasionally signs of heart strain can be detected, such as JVD, peripheral edema. The ECG may disclose normal sinus rhythm, sinus trigger, right axis deviation, and signs of heart strain, such as right bundle branch block and right ventricular hypertrophy, or the S1Q3 T3 pattern.
What is the electrical alternance here, or the low voltage?
Electrical alternance is look at the QRS complex.
Mm-hmm.
QRS complex is not similar. Look at the V2 lead. In V2 lead,
Mm-hmm.
in look at the V3 lead.
Mm-hmm. Of it.
Yes, this one. So if you look at this one is taller, one is shorter, one is taller, one is shorter. In the middle,
Okay.
yes, this is called electrical alternance.
Okay.
You search in the Google, in the Gemini,
Mm-hmm.
then you
No,
can easily,
I can see it here. You
yes,
can see it one small then big then.
yes. If you find this pattern in any ECG, that is electrical alternance, nothing to read. There is, there are some, uh, there are some diagnosis where electrical alternance is present, like pericardial effusion tamponade.
Okay. Previously, 42 men brought to the ED because of 2 hour history of severe abdominal and back pain. Temperature is high, pulse is high, respiration high, BP high in the right arm and low in the left arm. Breath sounds are normal, cardiac exam normal, femoral pulses are normal on the right and absent on the left. Labs, hematocrit, I don't know, leukocyte is fine, creatinine is high, so I'm believing urea is high too. Liver function tests are within range. X-ray of the chest is fine. Which of the following is the most likely diagnosis? Okay, let me check the hematocrit. Should be normal, but let me check. Hematocrit is low and urea is high.
BP difference in two arm and several pulses normal of the right muscle. Hmm,
I think I'll take that section.
is it
Terminal aortic aneurysm.
okay?
Thoracic aneurysm. Thoracic
Okay,
aortic.
it is aortic dissection. Aortic dissection. BP difference in two arm, one of the classic point and sudden severe. Okay, aortic dissection classically presents with severe acute tear in chest or abdominal uh, pain radiating to the back, differential blood pressure between extremities, and asymmetric pulses. With asymmetric pulses, dissection begins with the disruption of the tunica intima of the vessel, which permits blood to dissect the layers of the blood vessel to layers the vessel wall with each heartbeat. A dissection flap. A dissection flap may advance in any direction within the vessel, occluding or involving the branch aorta. If vessel takeoffs supplying the limbs are affected, if vessel takeoffs supplying the limbs are affected, pulse deficits or differential blood pressure may arise if splanchnic vessels are involved, and organ dysfunction such as mesenteric ischemia or acute kidney injury may be seen. Management may be medical or surgical, depends on the location of the dissection within the vessel type A and type B. Regardless the need for the surgery, all patients with dissection should receive immediate medical management to prevent further progression of the flap. Controlling the patient's heart rate and blood pressure is the priority in preventing progression. IV beta blocking medication should be used with the goal of lowering heart rate approximately 60 beats per minute and the blood pressure less than 100 to 120 millimeter of mercury systolic and 60 to 80 millimeter diastolic. Lowering the heart rate prevents the advancement of the dissection flap and resultant occlusion of the branch vessels by limiting the pulse pressure difference. Complications such as stroke, acute coronary syndrome, cardiac temperament may be immediately life-threatening.
Can you read CD?
Yes, ruptured abdominal aortic aneurysm. Ruptured abdominal aortic aneurysm classically presents with tearing abdominal pain radiating to the back and a pulsatile abdominal mass in order to classical abdominal mass in older patients with history of smoking, hypertension, connective tissue disease, or known atherosclerotic cardiovascular disease. Rupture first occurs in the retroperitoneal space, where it may remain transiently contained if exsanguination continues. Rupture may involve the peritoneal cavity, at which time rapid and unmitigated exsanguination can occur. Similarly, ruptured thoracic aneurysm presents with tearing chest pain radiating to the back, though unless branch vessels are involved. The physical examination may be normal apart from the variable presence of a murmur, the most common presentation of both aneurysm, which are often occult for years at the time of the rupture. Okay, okay. Can you just summarize the key point of this stem?
Which one? This one? I
Yeah.
was about to ask you the same thing. Like, how do
Okay.
you?
Like what I use to pick up this question, like in the aortic dissection we know that the classic like acute severe chest pain, back pain radiating to the back, this point is very important. And another classic point is BP difference in between two arm, like blood pressure difference in between the extremities. These two is the classic point for dissection.
Okay.
And like a Leerich syndrome, we know that there is a gut, sorry, in Leerich syndrome there may be infertility, and there is claudication. There is claudication, thigh claudication, maybe thigh claudication, one of the picture. And patient may have erectile dysfunction, thigh claudication, erectile dysfunction. This sort of feature is present, not like this type of severe chest pain. And in abdominal aortic aneurysm, like there may be abdominal pain, again like the dissection, but there is a mass, like presence of a pulsatile abdominal mass,
Mm-hmm.
not present in the aortic dissection. And we know that aortic dissection, according to the DeBakey classification, there is type A and type B, isn't it?
Mm-hmm.
So type A is acute, so surgery is needed. Type B is beta blocker is used. Okay. So and another thing like where
And
thoracic aneurysm,
mm-hmm.
ruptured thoracic aneurysm, again the chest pain radiating to the back, but there is a uh, they are saying that physical examination may be normal apart from a variable presence of a murmur. In thoracic aneurysm, there may be murmur. The
Okay.
most common of both, the most common presentation of both aneurysm. Okay. Thoracic aortic aneurysm is pretty different. And thoracic aortic aneurysm or dissection, syphilis is one of the cause, as far I remember.
Okay. Okay. Next. 67 woman admitted to the hospital 2 hours after the acute onset of pain in the left lower extremity. She has mild mitral insufficiency and chronic AFib. No medications. Exam shows cool left lower extremity and mottling of the skin of the knee. Sensation is absent below the thigh. Um, Okay. She's unable to move her left foot after undergoing left femoral embolectomy. Sensorimotor function is intact, and the left femoral popliteal, dorsalis pedis, and posterior tubers, everything, all the pulses are palpable. Transesophageal echo shows dilated left atrium without a patent foramen ovale or AV thrombus. Hmm. Which of the following is the most appropriate next step to prevent further embolization in this patient?
What he has.
Mm, Ready?
Okay.
Probably mitral valve. I feel like it's mitral valve replacement. Oh, no, that's right.
Okay, fib warfarin. Atrial fibrillation describes the uncoordinated contraction. Atrial fibrillation describes the uncoordinated contraction of the cardiac atria. Is cardiac atria and is often chronic left atrial enlargement caused by MR or increased left-sided pressure in the left ventricular hypertrophy with diastolic dysfunction when the atria do not uniformly fill and contract. Blood can become stagnant in the areas of the atria, especially in the left atrial appendages. Blood in the stasis is prone to coagulate, which results in the formation of the thrombus within the cardiac chambers. If a portion of such thrombus embolizes, many clinical syndrome can result. For example, strokes may occur when a thromboembolism occludes the cerebral occlusion. Mesenteric ischemia occurs when the mesenteric arteries are occluded. An acute limb ischemia occurs when an artery supplying an extremity becomes occluded. Management of atrial fibrillation includes anticoagulation with warfarin or a direct oral anticoagulant apixaban to prevent the formation of atrial thrombus, which reduce the risk of thromboembolic complication.
Can you read E? Sorry.
Yes, mitral valve replacement is appropriate in cases of severe or symptomatic mitral stenosis or regurgitation. Mitral stenosis or regurgitation, however, in the setting of left atrial enlargement and existing atrial fibrillation, replacing the valve generally does not reverse the presence of atrial fibrillation. Additionally, anticoagulation is indicated even in cases of paroxysmal atrial fibrillation because spontaneous conversion of or sinus rhythm to fibrillation may be undetected by patients.
1 week after undergoing appendectomy.
Today you have to go early, isn't it?
Yeah, probably in like 30 something minutes.
Okay,
Also.
no problem. I remember.
What is- Oh, you want to take a break? You
No,
want
no,
to
no. I have asked for uh, assure for assurance.
for a sure? Ah, okay.
I am not taking break.
Okay.
Okay.
1 week after undergoing appendectomy and peritoneal lavage for ruptured appendicitis, previously LT61 men evaluated because of fever, chills and cough, and mild shortness of breath. During the procedure, a peritoneal drain was placed. Postoperative IV ciprofloxacin and metronidazole were started. Persistent ileus was diagnosed on perioperative day 2. Nasogastric tube was inserted. Yesterday, the nasogastric tube was removed, and he was advanced to a regular diet. Today, temperature is high, pulse is high, respiration high, BP is normal. Pulse oximetry, oxygen is 94. Crackles are heard at the mid left lung field. Abdominal exam shows a clean dry incision. Peritoneal drain is mostly clear fluid. Leukocyte count is high though. Um, and I think segmented neutrophils are high. Chest X-ray shown. Which of the following is the most appropriate next step in management? Shortness of breath. Oh, microscopy for administration of vancomycin. What did they give him? Metronidazole and ciprofloxacin. I was going to say it's aspiration pneumonia, but I guess it's not. Or is it PE? I don't know. Oh, ready?
Okay.
So is it aspiration pneumonia? I don't know. This is a long explanation. Okay.
Pneumonia classically presents with acute onset cough, generally shortness of fever, chest discomfort, fever, chills, fatigue. Vital signs may show fever, tachycardia, tachypnea, hypoxia, hypotension if severe. On examination, bronchi and rales may be detected in consolidated lung, along with egophonia and dullness to percussion. Patients may have increased work of breathing or respiratory distress. The diagnosis is supported radiographically with air space disease or consolidation visualized on X-ray as shown here or on CT. Pneumonia arises because of the presence of the bacteria, virus, parasite, fungi within the pulmonary parenchyma, triggering an inflammatory reaction with resultant exudate into the air space. It is common in hospitalized patients because of risk factors for introduction of pathogen aspiration immunosuppressants, including recent surgery, swallowing disfunction, and intubation. Additionally, resistance pathogens often colonize resistance pathogens often colonize hospitals and equipment, increase the risk of refractory infection despite co-administration of the antibiotics. Treatment of hospital-acquired pneumonia generally begins with the administration of broad-spectrum antibiotics, especially those with covering of the MRSA and Pseudomonas aeruginosa, while awaiting culture and the sensitivity data from sputum samples if obtained. Suitable antibiotics for this purpose include vancomycin and third generation cephalosporin ceftazidime. Antibiotics should be narrowed to those suitably targeted the infectious agent once a clinical response is achieved. Reduction in risk factors should occur, and such as upright position of the patient, removal of any unnecessary pharyngeal lines of tubes, nasogastric tube, frequent respiratory therapy, pulmonary toileting, postoperative pain, often worse when breathing, should be aggressively managed to permit full chest excursion. and promote coughing and respiratory clearance and limit atelectasis. Okay, why not A? Aspiration of the ceftriaxone azithromycin in the setting of community acquired pneumonia because common pathogen is strep pneumonia and atypical Legionella. Neither of these agents sufficiently cover the hospital acquired pathogens. So as it is hospital acquired pneumonia, that's why we have chosen this
Mm-hmm.
Vanco and ceftazidime broad spectrum antibiotic. Okay,
Mm, okay. 67 men comes to office because non-productive cough, hemoptysis, and weight loss for 1 month. He has smoked for 50 years. Breath sounds are decreased over the right posterior hemithorax. Labs are fine. X-ray of the chest shows a collapse of the right lower lobe of the lung. Which of the following is the most studied pathophysiology of this patient condition?
breath sound are decreased on the right posterior.
Ready?
Okay, lung cancer often remains asymptomatic until advanced age, at which the tumor has locally invaded and or metastasized, leading to development of symptoms. The initial presentation is often non-specific and including weight loss and fatigue. Once the tumor has invaded or involved neurosensory and vascular structure, patients may begin to experience coughing and hemoptysis. If the lesion is too large enough to invade or obstruct the bronchus, patients may also experience post-obstructive or recurrent pneumonia. Post-obstructive or recurrent pneumonia in parenchyma distal to the lesion caused by atelectasis and impaired endobronchial clearance of mucus secretions inhale pathogens. In this patient, the the decreased breath sound over the right posterior hemothorax suggests the presence of bronchial obstruction to airflow. This is further supported by atelectasis on X-ray. In the corresponding area, squamous cell carcinoma and small cell carcinoma of the lung tend to be centrally occurring lesion, often seen in smoker non-small cell lung cancer, and other subtypes are more often peripherally occurring and may be more common in non-smokers because the significant morbidity and mortality with late diagnosis and screening of low-dose CT is recommended by the US Preventive 50 to 80 with a 20-year back history, a smoking history who is currently smoke and have quit within the past 15 years.
Previously healthy 32 men comes to physician because 6 month history of shortness of breath and dry cough. With exercise. He has smoked for like 5 years. Vital signs normal, faint bilateral expiratory wheezes are heard. Pulmonary function test shows a decrease, FEV1 normal. What happened here? normal FVC and decreased FEV1 ratio. The flow loop, what is shown, the diagnosis.
Is it obstructive lung disease?
Probably yes. Ready?
Yes. Okay, sir.
Shit.
I was pretty sure it will be as then I chose. So, okay, wait. Okay,
Oops.
asthma is a reversible obstructive lung disease, which is shortness of breath. Patients with reversible shortness of breath, cough, tachypnea, hypoxemia in severe cases, hypoxemia in severe cases, and increased work of breathing and wheezing on examination. It is often triggered by exercise, allergen, illness, smoke. It is characterized by reversible bronchospasm, which causes obstruction of the airflow generally. Exhalation is affected more than inhalation. The diagnosis is suspected based on clinical history and examination, and it is confirmed through pulmonary function test which disclose the obstructive pattern characterized by decrease in FEV1 and decreased in FEV1 by FVC ratio and preservation of the FVC. Flow volume loop generally disclosed abrupt decreases. Flow volume loop generally disclose abrupt decreases in the setting of expiratory flow rate compared to those of the unaffected uh, patient, which creates a concave appearance of the expiratory flow loop as the initial expiratory flow rate rapidly decrease in the setting of obstruction. Asthma can also be diagnosed based on reversibility or bronchospasm using beta adrenergic agonist or methaqualone. PFT will be disclosed or beta adrenergic agonist on exacerbated methaqualone obstruction. Treatment depends on severity of asthma, with cases of intermittent asthma requiring bronchodilators as needed, and elimination of the triggers. Persistent asthma is treated with corticosteroid and long-acting bronchodilator. Okay,
You read C, D, and E.
cystic fibrosis generally presents with childhood, may affect multiple body systems. Pulmonary effects arise because thick bronchial mucus preventing clearance of inhaled pathogen and leading to chronic bronchial inflammation, dilatation, air trapping, scarring, and known as bronchiectasis and known as bronchitis. Pulmonary function test and flow volume do generally reflect an obstructive pattern. Emphysema presence in a manner of emphysema presence in a manner of asthma with obstructive lung disease. However, the presence of bronchodilator may be compared to asthma. Emphysema results from the loss of the lung elasticity, which limits the degree to which small airways will be tethered open, and leading to generally irreversible obstructive pattern. Okay,
And E.
okay. Extrathoracic airway obstruction, when fixed, limits airflow in both inspiratory and expiratory phases. Such obstruction can arise from conditions such as malignancy, hematoma, or restriction. Pulmonary function tests reflects decreased FEV1. However, over A sufficiently long expiratory window would show comparable FVC and total lung capacity. Rate of airflow is limited because of increased resistance from airway obstruction. Flow volume loop display lower peak flow rates and flattening in expiratory and inspiratory loops.
So what would be the difference between the flow loop of asthma and emphysema?
Flow loop of an asthma and emphysema.
Yeah. So what would be the difference in this?
Mm, In
Is this on?
sorry,
Mm-hmm. Mm-hmm. Go ahead.
uh, I think that residual volume was one of the things. Flow volume loop. You should
I
see.
don't I don't think inner circle has those.
Sorry,
Like I don't think inner circle has the flow volume loops. Mm, because it seems like on this question we you needed to know the
know the flow volume loop. Yes.
how it work.
Other than that, you cannot. Asthma versus emphysema.
Asthma versus emphysema. Oh, it doesn't give you the actual thing,
So
the actual picture.
there may be a picture. Just copy that thing what you
Well,
have write in the
which one? Like this?
yes put it in the Google. Yes, go for image.
This one? Don't know. Or maybe this one. It's the same thing.
Look at that one. Not
Ah,
not that one. Go backward.
which one?
This one, the middle one, thoracic key. Thoracic key.
Which one?
This one.
Thoracic.
The thoracic
Oh,
key
right here.
where asthma,
Uh-huh.
restriction, everything is okay.
Uh-huh.
Look at the if you emphysema is more steeper. If you can compare that, yes, looks like somebody is sitting on your somebody's like somebody is sitting somebody's belly. Looks like emphysema is like that, and asthma is
What is the x-axis? What is it?
this is the x-axis, the thing you are.
But I mean, like, what is it? Is it is it because it's flow? So that's the volume and that's the flow.
Yes,
Okay. Okay. Uh, okay.
I have okay. I need to study to make you understand this.
Okay.
I need
Because here it makes this one makes sense. Okay, the volume is more in emphysema and less in asthma. Okay. But the flow, so the flow is going this way, I'm guessing. So the flow is less and here is more. Is that what they're saying? I don't know. Never mind. I don't. Okay, never mind. Because the volume makes sense. Because restricted, you see there is less volume coming in the
yes.
lung, so that makes sense. But the flow, I'm guessing the flow well when the FEV one when it's going out. So I'm guessing it's going out slowly. So that's why this word goes out slowly because it's going out slowly. And here in asthma, it's reversible, so it's going
If
out.
you match with our picture,
Let me see.
it looks like as it looks like emphysema. Look at the questions pattern.
Okay, you see, it matches. Never mind. We'll go with this.
It matches with the emphysema, not with the asthma.
It does. Yeah, it does a
isn't
little
it?
bit. It does a little bit. Yeah, yeah, it does. Mm,
So,
mm,
okay, if I got some clue, I will this I will try to describe.
mm-hmm. Okay. Yeah, because it does matches with. Because then there
Emphysema,
is no.
not the asthma.
Yeah, because then there is no other clue. I mean, volume is high. I mean, I'm guessing for all of them. But yeah, you the expiratory, the flow, it is going slowly though. That's true. Okay. Next. 27, 70 men comes to office because of 6 month history of progressive shortness of breath with exertion. Or maybe the other clue here was the fact that he only has shortness of breath with exercise. That may be another clue. I would have led us to asthma. Anyway, Oma, you there? I
Yes.
think. Okay. Right. 70 men comes to office because 6 month history of progressive shortness of breath with exertion. 6 months ago, he was able to walk 5 blocks before having shortness of breath. He now has shortness of breath after walking 1 block. He has not had chest pain, palpitation, swelling of legs, or shortness of breath at night. He has history of hypertension, medication, lisinopril, aspirin, no smoking, retired foundry worker. BMI is fine, pulse is fine, respiration fine, blood pressure I guess fine. Pulse oxygen is 94, diffuse crackles are heard, bilaterally cardiac exam normal, no edema of the extremities. Results of PFT shows FVC is 65, FEV1 FEV1 FVC ratio 70, checks X-ray is shown. What is the diagnosis? Ah, let's see. Foundry work. No, it's between silicosis and asbestosis, but foundry. What is foundry? What is
Boundaries.
what is
There
it?
is something like
We
fa-
know is
I
is
have
is
heard about founderies.
what is it?
Uh,
I mean, we know it's
uh,
fibrotic disease, but I'm like, is it foundry? Or what? I mean, what is anyway? Whatever.
uh, he retired foundry.
Because asbestos is the ship one,
Shipyard,
so
yes.
so foundry. Do they work in the ship? I don't know. Anyway, let's
Maybe
just ready.
aspergillosis.
Let's
Other
see.
the or silicosis.
Yeah,
What is foundry?
I don't know. Let me double check. Foundry organ. I guess this like metal. We work with metal cast. You see it?
Huh. Sorry. Yes. Okay.
They
Metal.
work metals.
Like, okay. Okay. Mm, pneumoconiosis describes interest ILD. Pneumoconiosis describes ILD arising because of inhalation and some small solid particulate matter such as dust or powder or talc, silica, beryllium ores that leads to the development that leads to the development of fibrosis with resultant restrictive lung disease. It is often seen in patients with chronic exposure, such as foundry workers, miners, cotton workers, farmers, stone drillers, sandblasters. The disease progress. The disease progress. Sorry. It is often seen in patients with chronic exposure, such as foundry workers, miners, shipyard workers, cotton workers, farmers, stone dealers, and sandblasters. The disease progress is often worsened by smoking. It generally presents with chronic symptoms of cough and shortness of breath on exertion. When severe or advanced, it can be associated with the need for supplemental oxygen and symptoms of heart failure. Core pulmonary diagnosis is based on clinical history, symptoms, examination, chronic. Okay.
Can you read A?
Yes, I was scrolling your screen. Okay.
Oh,
I am using two screen. That is the problem. Okay. Uh, Asbestosis arises because of chronic exposure to inhaled asbestos, which may cause restrictive lung disease and pneumoconiosis with similar pulmonary function tests showing a restrictive pattern. However, on imaging, asbestos often causes fibrosis of dependent and inferior portions of the lung and is associated with pleural thickening and nodular.
okay. 26. 68. More men brought to the ED because progressive severe cough, fever, lethargy over the past 5 days. She has 30-year history of diabetes, 20-year history of rheumatoid arthritis. Temperature is high, pulse is high, respiration high, BP is normal. She's lethargic, crackers are heard at the left lung base, and there is no less to percussion. X-ray of the chest shows um, left lower lobe infiltrated with an adjacent effusion. Pleural fluids, leukocyte count is 50,000. A lot of neutrophils. Glucose is like text. Let me check my glucose. Pleural fluid. This one doesn't have no pleural fluid thing. Never mind, my notes don't have it. Let's assume glucose is, I don't know. Lactic dehydrogenase is high. I don't know about the glucose. Which of the following is the most likely underlying cause of this finding? Wait, is the glucose high or low? I'm guessing it's low. I'm not sure.
Similarly, glucose around 50,000.
Ready?
1 second.
Okay.
Have you done the lights criteria in here?
I
Or
should have done it, but
or
maybe there's
or
like,
you just you know, okay. I think it's in Paima. Okay. Everything is higher. But the,
I
the
should have done it, but
this type of question actually this is as because the all the things are higher, that's why you have thought in Paima, but there is some clue in here.
yeah.
Okay. Pleural effusion Pleural effusion occur because of multiple underlying conditions, including infections such as empyema, pneumonia, malignancy, such as lung cancer or mesothelioma, or increased hydrostatic pressure, such as left-sided heart failure. They are clinically suspected when examination discloses dullness to percussion and diminished breath sound. They can be visualized on imaging, including chest X-ray, CT, ultrasonography. Clinical features such as immunocompromised history of malignancy or infectious symptoms, or signs of sepsis such as fever, tachycardia, tachypnea, lethargy, and can suggest the cause. Analyzing the pleural fluid uh, Analyzing the pleural fluid can further inform the diagnosis and increase cellular metabolism in the fluid and may include underlying malignancy or infection. Fluid can be categorized as transudate, serous fluid resulting from imbalanced hydrostatic pressure or oncotic pressure, or exudate, complex fluid resulting from pneumonia, empyema, malignancy, or inflammatory disease. Using Light's criteria, it compares the pleural fluid protein such as LDH and concentrate to those in the serum. Empyema is characterized by exudative effusion with increased pleural fluid, leukocyte, decreased pH, decreased glucose, increased protein, increased LDH. It is a known complication of the pneumonia which presents with cough, fever, tachypnea, infiltrate on chest X-ray. Management of empyema and evacuation via chest tube or surgery. Okay.
You read BC.
Yes. Okay. Malignancy may present with exudative pleural effusion and infiltrate on X-ray through unless superinfection is present, and would not generally present with acute fever and cough. Additionally, pleural fluid may contain malignant cell and would be less likely to contain predominantly neutrophil as primary cell type. And rheumatoid arthritis may cause pleural effusion associated with serositis. Unless superinfection is present, fever would be uncommon. Pleural fluid in rheumatoid arthritis is generally exudative, and its characteristics include lesion in neutrophil predominance and can appear uh, like empyema. Okay.
Okay, can we stop here
Yes,
today?
yes.
Okay,
Okay.
I'll see you tomorrow.
Okay.
Bye.
Bye bye.